So we've got some microphones that we'll be walking around with. So we've got about 10 minutes for questions. So we have one up the back there. If you could introduce yourself,
Thank you.
please.
Jeff Berry, I'm a consumer. Professor, what importance do you hold for families of the departed to be supported afterwards? In our local hospital this week, they had a service, non-denominational service, for the families of the departed and the health professionals that looked after them. And they're going to do that every year. I just wondered if that's something that you've thought about.
Well, thank you for this question. Well, I didn't have time to talk about families, but you know, in Spain, family is a big issue because we live in families, and they are very powerful in supporting patients and also in suffering because they share with patients their situation. So this is one of the main issues of this program of psychosocial spiritual care. One of the lines of this program is bereavement, not only after death, but before death, to allow families, to give families the support to be able to look after patients emotionally, but also practically and logistically, and also to prevent a crisis of reaction of families, of burnout or whatever you call this, and also to look after, to reduce the risk of complex bereavement, which is another issue. So I think any palliative care program must include bereavement and family care. We have this systemic approach, isn't it? So we are looking after families who have inside a patient instead to look after patients who have a family, because many times the family is more affected than the patient about the impact of the disease. So you are right. Yeah, thank you.
My name's Susan Trithiori. I'm a staff specialist at the Children's Hospital in Randwick, Sydney Children's Hospital. I'm just wondering how paediatric patients with palliative care needs are looked after in Spain, and is there interaction between specialist paediatric palliative care and general services?
Well, thank you for this. Well, in the psychosocial program, there are 3 teams that are specific for pediatrics because we were very keen to develop this. In Spain, there are 3 major experiences, one in Sevilla, one in Madrid, or 2 in Madrid, and 2 in Barcelona about this. And we are now, the Ministry of Health is developing with WHO a program to look after this issue, because, it's one of the challenges of planning is to look after conditions which are fortunately not very prevalent, but are very complex. So it's a debate about how to organize this. The model that we are proposing, and also at the WHO, it's a combined model, so having services of reference with good palliative care input there, with psychosocial and also palliative care input as a team, and then using the existing palliative care networks, training them and giving support to them to look after individual patients who are not in the metropolitan area, because, well, that's the debate we have. It's one of the priorities of WHO and also the Spanish Ministry of Health.
It actually sounds a little bit similar to what we try and do similarly here in New South Wales with that type of approach.
That could be one of the areas of cooperation, because the Ministry of Health in Spain is quite interested in this, and we are working in a policy, and we have an expert committee working on this. Thank you.
Thank you. My name's Genevieve McKinnon. I'm from Manly, and I'm one of the nuns at Manly Hospital, nursing managers. One of the issues we sometimes face is, from an oncology perspective, involving palliative measures earlier rather than later. So what measures did you put into place to try and engage oncologists who obviously would like to cure and rather involve palliative care a lot earlier than we involve them too late?
Well, that's another. Well, I think it's in oncology. I am formerly oncologist. I think I didn't tell you, but but they had this conversion to palliative care 35 years ago. And we work in a very good cancer institute, which has a very integrated palliative care. I think the response to this is integration. Integration means that we don't look at the prognosis, we look at the needs of patients and families, and we have an integrated model. The way to measure this is the length of intervention of palliative care service, which is almost 1 year in our institute. So during 1 year, the palliative care service is sharing with oncologists and radiotherapists and also hematology in the last 5 years, the care of patients. They talk about their cancer treatment with the oncologist, with quite integrated care, and also they talk about their psychosocial and symptom needs with the palliative care team. So I'm quite happy about this, and I think this is the model integrated. There is also, as you know, a taxonomic debate, because Eduardo Bruera and some other people at the MD Anderson say that we have to tell this or name this supportive care or whatever. But the model is integrating it. And also it reduces the over-treatment, and also but most of this is increasing the quality of life of patients much earlier, as in non-cancer patients. I think we are some years ahead of non-cancer because we have experience in the evolution of cancer patients, and we can identify easily this. So that's, I think, the model. Well, I don't know in Australia, but I think this is the way we propose.
I'm Peter Saul. I'm an intensive care specialist. The vision you have of the future is very exciting, but I wonder what the role of specialist palliative care then becomes, because you aren't going to have a massive increase in specialist palliative care to cover the massive increase in work. So who are the workforce that you foresee doing all of this?
Well, because I work also for this bank, they say if you have a wider perspective of clients, you must be very happy in general. So it's, but I think multiplying by 7 the candidates for a good palliative care approach is a good news for any specialist. But we have to change our perspective and change this late passive perspective of just keeping an eye on our patients, our institution, and open our window to look to cooperative models of care with other services. But I think the response is every service, these marinating processes, every service must develop policies of palliative care, of improving the quality in every setting, all services. It means that the model of intervention must be changed from a passive model to a proactive, propositive model. And from this, let's say, complaint model, the oncologist sent to me too late the patients, and it's a complaint-based model into a more, let's say, empathic model of cooperation with other specialists. But I have to say that I don't know in 10 years which can be the model of organization. We are now working in a multi-center project in Catalonia, bringing together acute bed hospitals called Improving Quality of Palliative Approach in Hospitals. And we are exploring some models of doing so. One model could be to change this fragmented perspective. It's for Lady Ramona, which is having all this disease, the cardiology, the COPD, the diabetes, the hypertension service, bringing together, especially based in nurses, which is a process of early identification and a joint process of care based in advanced care planning and case management, conducted by nurses, these nurses, and in which the role of the specialist palliative care service is a role of being competent in the essential needs and also some symptoms and cooperating with all these people. So this is the model. It's called, well, the acronym is UFMA in Spanish. Unidad Funcional de Malalt Avançat. Well, this is in Catalan, UFMA. It's not very good in terms of phonetics, but we'll try to develop the service. It's bringing together all these people in a functional way. We did the same with oncology, because in oncology many years ago, you went to a cancer institute and you have a first visit with medical oncology and then radiotherapy and then surgeon and then palliative care. And now we are working together. So we just go to one, and this is a policy that is joined by all the specialists. But the palliative care specialists, we have to find the essential aspects of our specialty, which is, I think, essential needs. Some of the symptoms are better trained by specialists. For instance, a good neurologist will know very well how to use drugs for delirium, perhaps better than me. So, but I can work with him and apporting my experience in difficult decision making, ethical decision making, end of life issues, spirituality, etc., etc. I think this is probably the way to respond to that. But we can explore this together. That will be a fascinating process of exploring ways of looking after patients in an effective and efficient way. And, well, we called about the 5 C's. One C is, it's competent. The second is committed with patients and families, conscious of all the dimensions and the needs of social needs, etc., and compassionate, and also cooperative. So if we have all these 5 C's that we were working with you yesterday, we will be able to improve the quality of care of patients. And we will enjoy also to be cooperative.
Dr. Green, Dr. Greenway at this table, and then another one up the back.
Sort of a couple of questions. One is the diffusion of palliative care competency into the community with integrated care. Inevitably, there will be our elders living in aged care facilities.
Yeah.
Did the resources, with your plan and implementing this in your home state, did resources flow into the community? Because one of the challenges we have here is that, in fact, they are removing registered nurses from aged care facilities at a rate of knots. And I can hear a moue of agreement around the room. And so what's happening is that unwell and dying patients land in the acute centre. And there are many, many vested interests. And the big challenge for us here too is the private sector. And so there are many vested interests in the care of people when they're most vulnerable. So the uniform approach and investing in nursing is a challenge.
Well, thank you for I forgot, we hadn't time to focus on this. But I mentioned several models of nursing because this is a huge challenge, and we call this the fourth world. So it's the third world is, some low middle income countries, but the fourth world is people in Barcelona in private nursing homes, not having quality of care, and with scarce, nursing, etc., etc. So I think this is a major issue because we have 50,000 beds of nursing homes with a high prevalence of people in need of palliative care, 60 to 70%, and high mortality. And then I think this is not resolved in our experience, but we have 3 models of working with this. One is, it was in one of the diapositives, is home care support teams focus only in nursing homes. We have 20. So we have 73 home care support teams, which are working with GPs in the community. But we have 20 more, which is 93 in total, who are acting specifically in nursing homes. So they cover 9,000 beds of nursing homes, these 20 teams. So they go as support teams. And there is another model which is based in primary care services, which is the geriatrics, says geriatrics of the X, which is the public health agency in Barcelona, and then these are GPs and nurses, public health GPs, having specific models of intervention in nursing homes, and they use also the NECPAL. These two projects they go to the nursing home, they use the NECPAL, the test to identify people in need. And the third model could be, we did so, it's implementing palliative care low complexity beds in nursing homes. Because this is the intensive care unit of a nursing home. Let's imagine a nursing home of 200 beds. And then you have a small palliative care low intensity unit for elderly who are in the community and need some support for dying. Or well, that's difficult because there is also a debate about the salaries because they earn less. So this is a major, I am telling about the things that we can propose to do, but this is not solved in our experience. That could be another area of cooperation because it's true that this is a major issue and it will be bigger in the next few years. Yeah.
So my question, I'm Belinda Perry, I work as the Quality and Clinical Complaints Manager at Ryde Hospital in Sydney. And my question is, how do you integrate all of the services into a medical record that people can see the broadness of, what's happening between the GP and everyone who's looking after it? Because I imagine that must be a huge challenge as it is for us.
Well, we are proud of this because in several regions in Spain, Galicia was the first. We have a comprehensive joint and shared information system. So if you are a GP, you can look at the story and also the analysis and all the X-rays done in the hospital the same day. So you can, and there is an alarm in our settings, is an alarm telling that you are accomplished or an advanced patient with limited life prognosis, and everybody can read it. To reduce the risk of misuse of this, it's mandatory that when you identify this patient and you classify this patient, you have to add clinical information relevant about the advanced care planning process and what you think could be a recommendation in crises that are preventable. For instance, you can say, well, this is a patient with advanced dementia. If something happens, we don't recommend this patient to go to the emergency service. We have talked with the family about keeping her in the nursing home, things like that. And also, the other way of working on this is we call the district model because we have these 39 districts, and we are, going to every district to ask them, and this is an incentive for them, to develop, we call pathways, is clinical pathways for advanced or complex chronic patients. So they have an incentive to work together, and we have a workshop that we did in Scotland, something like this, bringing together people of all the people in a sector, in a district, so it's emergencies, nursing homes, primary care, hospital care, together to talk about how to improve the palliative approach in your district. I think that's a good idea because it's, it's like cooking a seabed. It's marinating all services, and the sauce is the district project, and you can eat at the end.
One last question, just over here. Yep. And then we'll...
Are we on time?
Good. Yes. Last question.
Okay, thank you. Maria from Outcome Australia. And where is my heart? Yes. Then my question is related with my heart and my mind. And we knew last year about the excellent model in organ donation, and now this year we know about the excellent model in end-of-life care or palliative care that is happening in Spain. And then my question is, how do you think should be this marinated process between end-of-life care and organ donation, and what is happening in Spain?
Well, I knew you were asking this. Yes, thank you for this. I forgot my diapositive. You have to bring to me some diapositives on this. Well, this is a nice question. Well, I think this must be introduced in the advanced care planning process because, it's, one of the issues. So I think it's a good suggestion because we are now building this project of advanced care planning, training, and I think it's a good policy. It could be a good recommendation is inserting in the advanced care process of patients these as we are introducing the funeral things and all the other things about care and about dying also and about wishes and preference. That could be also an interesting issue to address. Yeah, I agree. You are right. He's my boss.
I think on that note, I'll ask you to join me all in thanking.
Thank you very much.